that wonderful talk. Now I'd like to invite Dr. Robert Ang, who's going to share with us something that we also face very often, is a shallow chamber or a patient with either pre-existing angle closure glaucoma or angle closure suspect who is now planned for cataract surgery. It's a pleasure to have you, sir.
Thank you for inviting me, and it's a privilege to be part of this instructional course. So, my talk is about dealing with angle closure glaucoma and cataract. So, I have these financial disclosures to make. So, the scenarios, there are three possible scenarios when we encounter angle closure. One is the benign primary angle closure, wherein they have narrow, shallow chambers, but nothing has happened yet. The next scenario is when there's an attack already and they come to you with an attack and with a glaucoma. And the third scenario is they've had an attack or they've had glaucoma for some time. The eye seems quiet, but they're there for cataract surgery. So these three scenarios may have a little bit of differences in approach. No? So the primary angle closure, the what we call glaucoma suspect, because of narrow angles, they're usually asymptomatic, narrow angle. If you check OCT, visual field, no damage. But you're alarmed because on the slit lamp, you see a very shallow chamber, a Van Herrick sign, and then you might want to do a gonio or an ASOCT to verify because the patient doesn't feel anything. So the patient sometimes doubts what you're telling them because they don't feel anything. No? Now you're there because you're concerned about any possible IOP spike, or if somebody suddenly dilates this eye, then they'll have a glaucoma attack in your clinic. Or when they're in phaco and they're dilated, they will have a glaucoma attack before your surgery. So you're kind of in a tough spot at some point because you want to avoid the disaster. So the options, there are two options actually. One is a YAG, peripheral iridotomy, or an outright phaco. So, studies, papers have been shown. So one of the landmark papers that came out was the Eagle study, wherein they compared, is cataract extraction a good idea for solving angle closure suspects? And of course, this was published in a Lancet, a very big publication. So it showed greater efficacy and more cost effectiveness if you do cataract surgery outright for these patients. But of course, some patients may not want to have cataract surgery, especially if their vision is still good. So there are other studies like the Zongshan study where it shows that even doing peripheral iridotomy is beneficial to tie them over. You know, these patients may not be ready, may not be willing, or may be suspecting that you just want their money. That's why you want phaco, no? Oh, surgery, so they pull back, no? So, but other studies comparing YAG-LI and phaco always show that phaco is better. So phaco is better. There are several publications about the benefits of phaco and prevention of angle closure afterwards. So what are the considerations in approaching these patients? Number one is what is the IOP? If they're low, then you're fine. But if they're like 20, 21, 22, and you document that they were 15 last year, now they're 20, they're 59, 60 years old or above normal, what do you do? So, option one is to convince them of a YAG-LI, no? And then you document patent LI, AC deeper, then you proceed quietly to a phaco. So that's my preferred approach, right? But usually I will document with an ASOCT so that they see that the angle did open up from a shallow one. But that's another cost. So you have to talk to the patients. Or they don't want a YAG-LI and they want to proceed. So I will give them an eye drop, for example, a Combigan or something like that, a dual acting, just to lower their pressure, even though it's normal, when you get into the cataract surgery. So you're kind of protected until the morning of surgery before you dilate them. Then do a phaco. Since there is no damage to optic nerve, you may proceed with the premium IOL of choice. No? So standard phaco techniques, If they want femto, of course, it's easier to do a capsulotomy in a shallow chamber if the femto is done. And the long-term prognosis is usually good in these cases. So, the problem is when they go into an attack. So, when they go into attack, the acute phase is the most difficult time because they have pain, blurry vision, redness, headache, the patient's panicking, distressed, and then when you see them, microcystic edema, frozen pupil. The cataract may not be dense at this time, but the AC is shallow and usually it's very high, 40, 45, 50 IOP. So your goal, if you see them the first time, is to break the attack. Break the attack meaning pour everything in, all the glaucoma category of medications. I do oral acetazolamide, 2 tablets right away, and then 3 times a day for the next 3 days. And then once I see that the pupil might react with pilocarpine, I will attempt a YAG LI on these patients so that I have something before I go into surgery and a mild steroid to quiet the eye. Most of the time, these maneuvers with the help of your glaucoma doctor will be successful in controlling the attack. So once stabilized, you have to keep the IOP controlled with all the medications. No? Now, what are your considerations going to surgery? Number one is your IOL calculation. You have a edematous cornea, shallow chamber, so you're not sure about your biometry and you're not sure about your optic nerve status. So if there's an attack, I usually will tell them, let's just stay with a monofocal IOL or a monofocal toric. You have to be ready with the pupil maneuvers because they usually have a fixed pupil. So they may not dilate more than the mid dilation, or they may be, if longer, they may look atrophied, fixed, and all that. So these are considerations to prepare for during surgery, and you want to be ready. Now, how to approach these patients? On the day of surgery, I will give routine mannitol. So I get a cardio clearance. I will always sedate the patient. And we do a retrobulbar anesthesia, even though it's just phaco with hynidase. And then I was taught in residency to put a lot of pressure. It's like you're mushing the eye, right? It's like you're squeezing the eye. No? We do that with corneal transplants too, right? We squeeze the eye so that you squeeze a little bit of pressure out of the eye. You may or may still not have a edematous cornea, and there was once where I had to de-epithelialize the corneal epithelium just to see what I'm doing. You want to decompress the lens if they're phacomorphic. There are papers, and we've done this in residency but not in private, where I had a retina fellow do a little bit of anterior vitrectomy or aspiration behind the lens. I didn't want to do it, but a retina fellow helped me do it. Now, one thing about the angle closure, sometimes they have a weird feel when you do a capsulotomy. I don't know if you feel that they don't tear as, they're not as robust in tearing, so they can extend out. And I've had several cases where the zonules were affected by the very high pressure. So we have to be very careful with this. I usually tap a little bit in the slit lamp to see if the lens is moving. But during phaco, sometimes you groove and you're pushing and then the lens is moving. So you kind of want to be careful. Adjust your technique for a shallow AC. At the end of near the end of it, in my last chunk, that's when I'm most afraid of high vit pressure. So I have a blunt instrument to protect it. And at the last parts of the surgery, I will usually relax the speculum. No? Relax the speculum so that you don't additionally push the eye. So these are all for high pressure. So options for these are trab only. So if my IOP is still 40, 45, 50, and all of these do not work, I have a backup plan where I tell the patient, we have to stage the surgery. We trab first, and then maybe after a month or two, when the trab is functioning, do the phaco later. If you control the pressure to below 25, I proceed with a phaco combined. So most of the time, I will do a goniotomy or GSL, but I'll show a video later of a MIGS with a phaco. And then you can do a phaco trab if really the pressure is high, you were able to do it, but the patient cannot afford a MIGS, then the trab is cheaper. So the factors affecting your decision are: number one, if you were able to control the IOP quickly, then there's a good chance that the TM is still functioning. No? So you might just need to do a phaco. But if still uncontrolled and very high, then you kind of need to find a way to solve this synechia. So the gonioscopic status is important, and your estimation of IOP after surgery is important. So this video is a phacomorphic, and I just want to show that I puncture. After I do vision blue, I puncture, and then I suck a lot of the milky cataract, just to decompress, because this happened to me before, that I extended when I punctured and then went out, no? And then it was a bad case after that. So decompressing, putting gel, and then even if the white materials oozing out of your wound, but you're able to complete a capsulotomy. So it's easy if your capsulotomy is intact. So another maneuver that I do is, if I feel that if the pupil is frozen, no, at the end of the case, I will usually do this. I would pull the iris towards the middles with my IA, so that it's like peeling your PAS in a certain part. So I try to pull it, because I think that the goniosyneculasis, just pushing it, is not enough. So I just pull and tear it away from the angles. No? So chronic angle closure is actually more common than angle closure attack, because somebody has probably solved the attack and they come to you later for the cataract surgery, maybe months or years after. So the course of action depends on how severe the cataract is. So the pupil may be atrophied, so I do that pulling maneuver. You may have synechia on the pupil or on the angles, so you have to deal with that. And then avoid usually a multifocal because of the compromise in optic nerve. And your conjunctival status might be cooked because of prolonged meds. So combinations of surgeries, again, I would probably combine it with glaucoma surgery with phaco. And these are studies saying that, actually more studies are saying that phaco only is good. Don't combine with anything. So, but then these are probably expert doctors, but you're on your own, so you want to do something in addition. So I did a study on chronic angle closure glaucoma with a MIGS, a hydrus, and as you can see here on the left column, pre-op, many are on 1, 2, or 3 meds, but post-op at 12 months, only one patient had 1 med. So it is actually very rewarding to put some MIGS in this kind of patients. So this is a video of, So I do, after the phaco, I do the phaco first to open the angle, and then if there's still some synechia, I would do some of this GSL, goniosyneculasis. I would open just maybe 1 to 2 clock hours, so that it's visible enough that I see the scleral spur. I have to identify the TM, and then I would put this hydrus. No? The hydrus is now owned by Alcon. So Alcon will release this, and it's a long stent or MIGS. And you see that if you test it with vision blue, you will see that there's a leak in the conjunctival vessel. So if you test it, you will see that, it's patent, and it's working. So in these patients, patients initially were all closed, half or 360 degrees closed, and then at the end of 12 months, maybe more than 90, 80, 90% are less than half closed. Still some areas of closure because I did not do GSL all over, no? But it helps. And then if you see the angle, so this is the reason why the hydrus is what I like for angle closure is it's like a straw, you know, the part of it is jutting out of the anterior chamber. And even if later on you see that some of the areas are becoming synechia again, no? The pupil creeps up, and even if you do GSL, it will close again because of the hydrus jutting out. It still drains fluid behind the TM. So this is like 360-degree closed again, but since this is open, the inlet, then it kind of drains fluid. So in summary, controlled IOP prior to surgery makes your life easier. So we do gonyo. Most doctors don't like to do gonyo, but you have to do gonyo at least pre-op. Adjust technical difficulties, adjust your IOL choice depending on the damage, and monitor the patients post-op. Thank you.
Thank you so much for that excellent managing all different variations of angle closure along with cataract surgery. I had a couple of questions. One is, say if it's a angle closure suspect, you haven't done a PI, patient is agreed for cataract surgery, IOP is borderline. So in such, and you have generally you avoid dilating them except on the day of surgery. So on the day of surgery, even if there is no angle closure attack or previously, would you still consider giving a mannitol before dilating them?
Yes. I would. So I would do first. They probably will be on eye drops, even the morning of the surgery, because anything that you can do to decompress the posterior is good because that can go up to you during surgery. And I usually will do once medically cleared. I will usually give like 100 cc to these patients, just for my peace of mind during surgery.
Absolutely. And the second question is that particularly when the patient has had an attack and has a fixed pupil, say around 4.5 millimeters, at the end of surgery, would you consider, making the pupil smaller with some form of pupil repair, pupilloplasty, or you find that?
Yeah, the pupilloplasty is a tricky question because you want to be able to see the posterior and test the visual field. If you fix the pupil somehow, then you cannot check the visual field after. So leaving them a little more dilated, that's why I do that maneuver just to push. But I would rather leave them a little more dilated than constricted for monitoring purposes. That's why you want to put just a monofocal IOL.
Correct.